Hello, everyone, and welcome to today's CASLPO e-forum on the practice standards for the Controlled Act of Prescribing Hearing Aids. Thank you for taking the time to join us today. We will begin with a territory acknowledgement. As this e-forum is virtual and we are not all gathered in the same space, we would like to take the time to acknowledge the traditional territories we are on. We acknowledge that the CASLPO office is located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. We acknowledge that Tukaranto, a Mohawk word meaning the land where trees stand in the water, is covered by Treaty 13 with the Mississaugas of the Credit. These lands are now home to many diverse Indigenous peoples and communities. We are thankful to the peoples who have since time immemorial cared for Turtle Island, which includes the land we now call Ontario. Acknowledging these traditional Indigenous territories is one way for us to recognize the rights and history of Indigenous peoples. It is also a small way for us to work towards dismantling the continued impacts of colonialism. We are all members who share a dish with one spoon, which teaches us to live on these lands with respect, nonviolence, and sustainability. Thank you again, everyone, for joining today. My name is Samita Joglekar, and I'm the advisor for audiology practice and quality assurance, and also a registered audiologist.
Hello, my name is Dana Frucci, and I am CASLPO's Director of Professional Practice and Quality Assurance, and I'm a speech-language pathologist. As always, we like to start just reminding you about how to watch the e-forum in case you have any technical difficulties. It's best if you have every other program that's running on your computer closed. If you do have difficulties, then close the e-forum and then join back again. The recording and the slides will be published on the CASLPO website shortly. Please do send your questions in today to us. We are going to answer as many of them as possible. If we don't answer today, then we will get back to you afterwards directly. And you'll see there's a little orange arrow on your screen somewhere, depending on the device that you're using, and that'll let you open up the questions. So really today, we wanted to answer how audiologists can perform the Controlled Act of Prescribing Hearing Aids for adult patients according to CASLPO standards when relying on information provided from hearing instrument practitioners, or HIPs. And the information provided to an audiologist from a HIP could be from a patient assessment or other gathered information, as we'll discuss. For some audiologists, prescribing hearing aids in this manner represents a change in practice, especially for those audiologists who are not currently working with HIPs in the same workplaces or otherwise. Today, we'll start by reviewing the Assistive Devices Program changes that led to the recognition of this new practice situation coming up more frequently. We'll talk about the Controlled Act, what it means and its importance. We'll talk about prescribing while relying on information gathered by HIPs, including 2 scenarios to further understand how prescriptions can be done according to CASLPO standards of practice when patient assessment information is gathered and passed over to an audiologist from a HIP. Finally, we'll touch on records and payment, and at the end, we'll have some time for questions.
Thank you, Dana. So let's get into the first section of the e-forum, which is on the ADP changes and how they relate to the current practice situation. So this practice situation of audiologists being asked to carry out patient hearing aid prescriptions, working more with hearing instrument practitioners, has to a large extent resulted from the changes announced by the ADP beginning in January of this year. So there were 3 announcements that came out from the ADP on January 24th, 28th, and the last one on March 27th. And we're just going to review the major outcomes of these ADP announcements. One outcome is that physicians are no longer required to sign ADP forms. So family doctors have signed ADP forms as prescribers for many years. Their signatures on ADP forms have been taken as evidence that a valid prescription process for hearing aids has been carried out by the physician to determine a patient's need for hearing aids according to the standards of practice for physicians. CASLPO's understanding is that due to a shortage of family physicians in Ontario, the profession wishes to reduce the administrative burden of paperwork and to have time for important patient care in other areas. While physicians still have access to the controlled act of prescribing hearing aids, Castlepo's understanding is that physicians may wish to be less involved with prescribing and signing the ADP forms. A second outcome of the ADP announcements is that audiologists are no longer in need of a second signature on the ADP form from a non-financially related regulated professional. This was a financial conflict of interest rule that the ADP had put in place that has now been removed. And this removes the barrier for patients in that when a patient sees an audiologist, they don't need to have a second signature to access ADP funding. And this was done with the recognition that audiologists are a regulated profession. They have access to perform the Controlled Act. That has been the case with the Regulated Health Professions Act always. And audiologists are required as regulated professionals to follow all applicable laws, regulations, and standards, including those for conflict of interest. A third outcome of the ADP announcements is that the ADP has determined that hearing instrument practitioners can continue to sign as authorizers for adults who wish to have their hearing aids funded through the ADP. We feel it's very important to point out that hearing instrument practitioners require a prescription for hearing aids from a regulated health professional authorized by law to prescribe hearing aids before they can dispense. And this is a requirement that is in the Regulated Health Professions Act in sections 27 and 31. So let's have a closer look at these sections of the Regulated Health Professions Act. Section 27 prohibits a person from performing any of the controlled acts unless the person is authorized by a Health Professions Act to perform the controlled act. The only professions authorized by an act to prescribe hearing aids are audiologists and physicians. This does not apply to hearing instrument practitioners who are not regulated professionals in Ontario. And the law around who can perform this controlled act has not changed. Audiologists are authorized to prescribe hearing aids by the Audiology and Speech Language Pathology Act, and physicians are authorized by the Medicine Act. Looking now at Section 31 of the RHPA, Section 31 makes it a provincial offense for any person to dispense a hearing aid that has not first been prescribed by a regulated health professional, either an audiologist or a physician. And contravention of Section 31 is punishable by fines, and these fines are outlined in the RHPA. It's up to $50,000 for individuals and up to $200,000 for corporations. It's also important to note that based on this section of the RHPA, the Controlled Act cannot be delegated. And this is because it is a provincial offense if either an audiologist or physician does not prescribe a hearing aid that is going to be dispensed. So we are going to talk more about delegation later in today's session. So just to recap, hearing instrument practitioners can continue to sign as authorizers for ADP funding for adults, but they require a prescription for hearing aids from a regulated health professional who is authorized by law to prescribe hearing aids before they can dispense. And we have just reviewed the sections of the RHPA that support this, and this requirement has not changed because the RHPA has not changed. Castlepo's understanding is that physicians may wish to be less involved in this process, and therefore, audiologists play a very crucial role in performing the controlled act of prescribing hearing aids with the required knowledge, skill, and judgment. This is because audiologists are the only other regulated health profession that has access to perform this controlled act. Hearing instrument practitioners are unregulated in Ontario and do not have access to perform this controlled act. So as audiologists, we know that we are working with a vulnerable population. Hearing loss can be a complicated issue, and treatment with hearing aids isn't always straightforward. In the area of hearing aid services, the public is relying on our profession to be ethical, skilled, knowledgeable, and patient-centered in performing the controlled act and providing quality service. If we put ourselves in the patient's shoes, we can more easily understand the importance of regulation in hearing healthcare. Our patients and their relevant others need our support, and they are trusting us to put their best interests first. It is beneficial for the public to see regulated health professionals who are held accountable to meet standards, especially when it comes to a controlled act that is associated with risk of harm. So if you have not already, we strongly encourage you to review the FAQ document that CastlePo published in April of this year. This document clarifies several misunderstandings around what the ADP form represents and what the law requires for hearing aid prescriptions and the Controlled Act. So the FAQ document clarifies the terms on that form, the purpose of the form, and how audiologists should use the ADP form. The FAQs also talk about the standards for managing conflict of interest that audiologists are required to follow. The FAQs do talk about prescriptions for patients who have been assessed by a hearing instrument practitioner. And there is an included sample prescription checklist and form. And these are resources that have been provided to guide audiologists on what the standards are and how to meet them. So these can be used as resources for your reference. An important takeaway is that the ADP is a funding assistance program, not a regulator. The ADP is for Ontario residents to access funding that will help them with the purchase of hearing aids if they meet the criteria set by the ADP to receive that funding support. When we as audiologists sign an ADP form to assist our patients with accessing this important provincial funding, that is not performing the Controlled Act of prescribing hearing aids. You will have performed the Controlled Act by the time you sign the ADP form, but your signature on the form and the form alone does not meet the standards for performing the Controlled Act. It is always an important message that audiologists are always required to meet standards of practice as regulated health professionals. And this applies in all practice situations, and it does not depend on the ADP. CastlePo cannot make decisions about the RHPA or about ADP policies and procedures. These things are not in CastlePo's control. The college has to regulate audiologists within these existing frameworks. So please continue to contact the Assistive Devices Program if you have questions about their policies and procedures, and continue to contact CastlePo if you have questions about regulatory requirements and standards. So the remainder of the session today will not focus on the ADP. What we are going to focus on now is the regulatory principles and the standards for prescribing hearing aids and the relevance of this Controlled Act and the standards to the current practice situation. We also want to say that CastlePo wants to support audiologists in meeting standards of practice. This is what is best for our patients and for our profession. This session is not meant to be stress-inducing. CastlePo is aware that the majority of audiologists are making every effort to be compliant with standards and are focused on providing the best patient care possible. We want to be clear about what the standards are and how you can meet them, and we want to support you as much as possible to meet standards. But the college must do so within its role as a regulator while working to protect the public. So let's move now to the next section of the e-forum, where we are going to talk about the Controlled Act. What does it mean to prescribe a hearing aid? So let's talk about what the concept of a Controlled Act is and what it means for our profession. The Regulated Health Professions Act includes 14 controlled acts, and one of them is prescribing a hearing aid for a hearing impaired person. And it's important to realize that out of the hundreds, potentially thousands of acts of intervention that happen between health professionals and patients, only 14 acts have been determined to be controlled acts. Here are 5 other examples of the 14 controlled acts in the RHPA. And these are activities that have been determined to be inherently hazardous and potentially harmful activities if not performed with appropriate knowledge, skill, and judgment. And therefore, it has been determined that these activities must be performed by or under the supervision of regulated professionals who have the knowledge, skill, and judgment acquired through their education, training, and development of competencies. So it is no small thing that audiologists have been granted a controlled act, and we must not, as a profession, take this controlled act lightly. Controlled acts are very important for public protection. They are grounded in the legislation, and we must take them seriously. So when we're talking about inherently hazardous and potentially harmful activities, we're talking about risk of harm. And the overarching risk of harm of an improper prescription process is the risk to communication outcomes for our patients. So are patients having less ability to participate in important life activities that involve hearing and communication, and this reduced ability to participate being due to a hearing loss that has not been appropriately identified, analyzed, and treated through an appropriate prescription process. So in terms of physical risk of harm of an improper prescription process, this can be things like under or over amplification, fitting to targets, issues with physical fit, which could cause additional discomfort or pain, and difficulties hearing environmental sounds that are important, which pose a physical risk of harm. For children, the risk of harm is substantial and well established. An improper prescription process could pose risks for language acquisition and development, in the long term with literacy, social communication, and educational opportunities. The risk of harm for adults is also well established of an improper prescription process. This could be social isolation and reduced participation, loneliness, perhaps problems with cognition, and risks to vocational opportunities and advancement. And then again, for all patients and their relevant others, the risk of an improper prescription process would be suboptimal benefit of hearing aids due to insufficient counseling and support during the prescription process. And then of course, importantly, financial risk of harm, because audiology services and hearing aids are of course expensive. So as you can see, the risk of harm considerations here are substantial and well established and include physical, but also emotional, psychological, and financial risks. We're talking about the Controlled Act, and so again, it's important to say that the RHPA prohibits a person from performing a controlled act unless the person is authorized by law to perform it. And having just looked at the risk of harm, I'm sure we can understand why this makes a lot of sense. Audiologists and physicians are the only two professions authorized by law to perform the controlled act of prescribing hearing aids. And audiologists have been granted this controlled act because the profession is recognized to have the knowledge, skill, and judgment that is required to protect the public for this high-risk activity. And this is also supported by the fact that audiologists are regulated and held accountable to meet standards. We also think it's important to say that audiologists can prescribe hearing aids for patients across the lifespan. So our discussion today on hearing aid prescription when working with hearing instrument practitioners is focused on adults. Hearing loss intervention for infants and children is to be provided by audiologists. And we make this statement based on the risk of harm considerations for children, which we've talked about and which are substantial and well established, based on the fact that the education that audiologists receive through their degree programs places focus on hearing loss intervention for children, and also based on the fact that both the Ministry of Health that oversees the ADP and the Ministry of Children, Community and Social Services that oversees the infant hearing program in Ontario will only fund services and prescriptions for infants and children when they have been provided by audiologists or other regulated professionals. So let's talk now about what exactly is involved in performing the controlled act of prescribing hearing aids. Section H in the practice standards for the provision of hearing aid services covers all of the aspects of hearing aid services, including the minimum standards for the activity of prescribing. And when we're talking about the activity of prescribing, the controlled act, we're talking about determining the candidacy of a patient for hearing aids. And this is going to involve several things. It involves comprehensive patient evaluation, which would include thorough audiological assessment, and then determining the need of an individual for hearing aids based on a holistic consideration of that individual. And then the act of issuing a prescription for the dispensing of specific hearing aids for an individual based on that comprehensive evaluation. And it's these two activities together that are the controlled act of prescribing. We then have other very important hearing aid services that are informed by the prescription process in A and B. So a question that has been raised is, isn't the act of prescribing everything from A to G? Now, of course, if you are an audiologist and you're doing everything from A to G and providing all of these services, then you are required to provide all of these services according to the minimum standards. But when we are talking about the controlled act of prescribing hearing aids, we are looking at this as the processes of A and B, because we are recognizing the reality in practice that there are situations where audiologists are only doing the activities in A and B, and then the patient may go elsewhere for C to G, the dispensing, the fitting, the verification, and the follow-up. The patient might be going to another audiologist for C to G, in which case the two audiologists must collaborate for the benefit of the patient. In some cases, the patient might be going to a hearing instrument practitioner for steps C to G, with the information about the controlled act and the prescription having been provided by an audiologist and confirmed by an audiologist, because that is the important part, as we've discussed, that is the controlled act, and that is the part where audiologists must be involved. So when we're talking about prescription, we are talking about the activities in A and B, and as audiologists, if we think about what we're doing to determine candidacy of a patient and the act of issuing a prescription, we can see that this is not an administrative task covered by cursory review or signing a form. There must be application of patient-centered clinical knowledge, skill, and judgment in performing this activity. It is a controlled act. We know as audiologists that it is not the case that every individual is a good candidate for hearing aids or that they will benefit from hearing aids. It's not the presence of hearing loss alone that determines an individual's candidacy for this treatment. I remember when I was a student in my master's degree, a clinical supervisor of mine would say, "Your return rate on hearing aids is a direct reflection of your success as a clinician." And I think what he meant was that an audiologist should only be prescribing hearing aids for people that truly need and will benefit from them. This is a healthcare profession, and we are healthcare professionals. When we are patients, we trust that our healthcare providers have the skill and knowledge to recommend treatment that we truly need, and that they will not allow personal or financial factors to interfere with placing our needs first. And this is what patients are looking for from us. So this is not a cursory review, it's not an administrative activity, this is a controlled act. And when we're determining candidacy and talking about holistic consideration of a person, the practice standards talk about many other factors besides a detected hearing loss that we must consider as audiologists when determining a patient's candidacy. So not just the case history and assessment data, but also the communication needs of our patients, the lifestyle and personal factors, health and social factors. Are there barriers to successful outcome with hearing aids? Will there be impacts on use, care, and maintenance of hearing aids? Are there cognitive issues to consider? Are there dexterity, vision, or other issues to consider? What is the patient's potential for obtaining benefit from hearing aids as a treatment? What is their level of motivation? We need to counsel patients to make an informed decision, including about the financial considerations. And this is why this is not an administrative task. As audiologists, we are educated to have a broad understanding of hearing loss and a holistic view of our patients and how disorders of hearing, balance, and communication impact the whole person. And we know that a detected hearing loss in and of itself is not the only factor that determines whether hearing aids are the best treatment option or even an appropriate treatment option.
So we're talking about the importance of prescribing. What does it mean? Prescribing involves a comprehensive and thorough assessment and analysis that leads to a patient-centered determination of the need for a specific treatment. The quality of an assessment directly informs the value and benefit of a prescription for treatment. Any professional that prescribes something for a patient will assess and analyze using their professional judgment. This may seem obvious, but it's worth reviewing to remind ourselves of the importance of this act. We've looked at what other health regulators say about the activity of prescribing or recommending a treatment. The College of Optometrists of Ontario says a prescription is an order between an optometrist and a patient based upon the analysis of all available clinical information and subsequent diagnoses from optometric examination. You can see here that the idea that prescribing involves analysis of information from an examination to develop a specific order for something for a patient. In this case, probably corrective lenses for a vision loss. Occupational therapists need to identify gaps in the assessment findings and decide whether additional information is needed, and to analyze findings and outline recommendations in the context of each client and their specific situation. We see here the ideas of identifying when more information is needed to draw conclusions, analyzing findings, and making patient-centered recommendations. Additional things the Occupational Therapy College says about prescriptions are that occupational therapists need to analyze clients' strengths, challenges, contexts, and the impacts these have on an occupational participation, and develop evidence-informed recommendations based on the analysis of the information gathered. So it's not just the assessment data, but also information about a person's specific needs and capabilities. And then an analysis of all this information is taken together to develop evidence-informed recommendations. From the College of Physicians and Surgeons of Ontario, physicians must ensure knowledge, skill, and judgment to prescribe safely and effectively. They must undertake an appropriate and thorough clinical assessment and determine clinical indication based on the assessment and analysis of other gathered information. And at CASLPO, we say that the act of issuing a prescription for the dispensing of a specific hearing aid for an individual is based on a comprehensive evaluation. And this really shows agreement between health professional regulators when it comes to the principles behind what it takes to prescribe something for a patient. Having looked at these colleges, we see that prescription necessitates assessment, evaluation, filling in gaps, considering other potentially clinical or non-clinical information, analysis of this information in a patient-centered manner, and then developing the prescription, all of which requires application of knowledge, skill, and judgment. Okay, so this might seem like a good time to take a brief pause for a question. If it's okay, Sumit, I'm going to start. I see that there's one. Is dispensing hearing aids a controlled act? In Ontario, only the prescription of the hearing aid is the controlled act. Dispensing is not, so patients can go anywhere and see a hip, for example.
Yes, and I would add to that that's true, but the controlled act is the prescription as we've covered. So the prescription must have taken place with a regulated health professional before the patient can go wherever they would like to have the hearing aid dispensed. That important prescription step has to have taken place. I do see a question here. Within A of the controlled act, an audiological assessment is included. Does this mean the audiologist must retest if the patient comes with an audiogram from someone else? So it depends on how thorough that audiological assessment is, whether or not you feel you have all of the assessment data that you need to proceed. So if there's something missing in the assessment data, a gap that you think needs to be filled, if you think there's additional testing that needs to be done, then the standards would require us as audiologists to take those steps, do retesting or another assessment if we feel that's necessary. So that's application of your judgment in terms of what you think is needed. If the assessment data is complete and if it's a complete what you've received and you feel it's thorough, then you may determine you don't have to retest, but you might determine that that's necessary depending on the patient and the circumstances. Okay, I think we're going to leave it there and we will continue and we'll have time for more questions at the end. So let's move now to the next section of the webinar where we will be talking about prescription relying on information gathered by hearing instrument practitioners. So how to do this according to standards of practice. So looking at our diagram here of what is involved in the controlled act. So this involves audiologists carrying out the activities in A and B, which is the controlled act, when patient information has been gathered by a hearing instrument practitioner and passed over to you for review. And as we've talked about, audiologists must be involved in that step, in the steps of A and B, because as we've covered, this is what the legislation requires, and this is the regulatory oversight that's necessary to protect the public. Knowing that in some situations, the patient is going to another place for C to G, and that these services may not be carried out necessarily with an audiologist's involvement or supervision. So let's talk about how to do A and B according to Castle Post standards, the activities in A and B, when relying on information about a patient that is provided by a hearing instrument practitioner, and remembering that this only occurs for adult patients. So we would imagine that there are two different major practice situations where this could be occurring. The first would be where the audiologist and the hearing instrument practitioner are working in the same setting, in the same clinic. And in that case, they possibly already have a working relationship. They have knowledge of each other's competencies, and patients should generally know who they are interacting with, the role that each professional plays, and record keeping and payment would all be happening in one setting. A second practice situation is where the audiologist is working with an independent hearing instrument practitioner who they do not already work with. And in that case, there is the need to develop a collaborative professional relationship. There's the need to understand each other's roles and competencies. And we would imagine that this potentially would be more challenging for patients in terms of understanding the role of each professional, the service that is being provided by each professional, so the importance of what the audiologist is doing in this case, and record keeping and payment, which could be happening in a different way. So let's put this into practice by looking at two scenarios. We're going to work through two different scenarios, and we just want to say that these scenarios are fictitious.
Dara is an audiologist and Cami is the hip, and they work together in the same clinic. They've been colleagues for many years and have a respectful professional relationship. Their patient is Sam. Sam is 78 years old, and he has been seeing Dara and Cami for 6 years. He has come in for his annual checkup. Sam has bilateral, symmetrical, mild sloping to moderately severe age-related sensory neural hearing loss. He has a diagnosis of diabetes. He has loss of vision and numbness in his hands. He thinks that his hearing has gotten worse in the last year, and he needs to turn the radio and TV volume higher than before. His current receiver in canal hearing aids are 6 years old, and he wants to discuss getting new hearing aids, and this is his third set. Cami conducts Sam's hearing assessment and sees no significant change in his audiogram. In addition to getting the audiometric data, Cami passes on to Dara the following information. Sam reports slight decline in his vision, no overall health changes otherwise. The otoscopy is unremarkable bilaterally, type A tympanograms bilaterally. Speech audiometry results, there's a slight decline in the word recognition score. And Sam is an experienced hearing aid user. Communication needs, lifestyle, personal factors, motivation, goals, and expectations have been reviewed, and they're well established for him. Other information from Cami is the details of the discussion on suggested models, brands, features, and costs of new hearing aids. And Sam would like to access ADP funding for his new aids, as well as recommendations for additional counseling on hearing aid positioning based on increased vision loss and hand numbness. So it is time for our first poll that I'll launch. And so we'd like you to answer what you think about this. Can Dara, the audiologist, determine Sam's hearing aid prescription based on the case history, audiometric data, and other information that have been gathered by Cami the hip?
You can see the responses coming in. Thanks for your participation.
All right, I think we'll give you 5 more seconds.
Yeah.
All right, so I'm going to stop the poll. And share. Thank you so much to everybody who voted. So I think we have a vast majority, 72% said yes, 17% said no, and 12% were unsure of whether this is something that Cami can do. So the answer that we have is yes. This is a situation where DARA can prescribe. And so let's see what the standards require DARA to do. DARA must review all the information about the patient, identify risk factors, and take steps to fill potential gaps in patient information, and to determine and document the final prescription based on a thorough analysis of the patient information. This is made easier by the fact that DARA and CAMI work together and they collaborate well. So, what does DARA do? DARA discusses the assessment results with Sam. He agrees with several of CAMI's recommendations, and DARA reviews the details with Sam to ensure that Sam is comfortable with the decisions. DARA decides to do a quick speech and noise test to further evaluate the change in Sam's word recognition score. He also conducts a COSI to see if any of Sam's goals of amplification have changed. DARA determines the final hearing aid prescription, having thoroughly reviewed and considered all of the information gathered. He documents the prescription in the patient record along with the clinical rationale. The ADP form is completed to facilitate access to provincial funding towards Sam's hearing aid purchase. DARA can reference the CastlePro prescription checklist that was provided with the FAQs because it's based on the standards. Note that the ADP form is filled in after the prescription process has been properly carried out. So let's think about what DARA has done. He's taken all the information from CAMI and evaluated it and determined Sam's need for a hearing aid. He didn't do all the testing or information gathering himself, but his comprehensive patient evaluation is his analysis and detailed patient-centered review. In this case, by reviewing the information and determining the prescription, he has prescribed according to CastlePro standards. It must be clear in the documentation who has carried out what. DARA must document the hearing aid prescription and the clinical rationale for the prescription. The audiologist is accountable for performing the controlled act and for the hearing aid prescription. So it is time for another poll.
Yes, we're going to ask another polling question based on this scenario. So in this scenario, DARA knows CAMI. They've been working together for a number of years. He knows CAMI's competencies and he trusts CAMI's professional judgment as a hearing instrument practitioner. So the question we're asking is, to make things easier, can DARA, the audiologist, delegate the controlled act of prescribing hearing aids to CAMI? We'll just allow a few more seconds for your participation in the poll. Okay, I think we can close and share the results. And I think everybody's looking at the results now, so you can see 97% of attendees are saying no. The audiologist cannot delegate the controlled act of prescribing hearing aids. And so let's have a look at our answer. And we also are saying no, this cannot be done. So as we've covered in the earlier part of today's session, controlled acts must only be carried out by regulated health professionals. There's a risk of harm associated with all controlled acts. And as the prescription of hearing aids is a controlled act, it cannot be delegated to unregulated health professionals. So DARA has to perform that controlled act. He has to come in for that part. We can see in the scenario, he's taken some steps. He's spoken to Sam, the patient. He's reviewed all of the information. He's done some additional testing. So what has happened in this scenario between DARA and CAMI is not delegation of the controlled act. CAMI, as a hearing instrument practitioner who is collaborating with DARA, has collected a lot of information about Sam, but DARA is performing the controlled act himself, using the information that CAMI has provided and applying his education, knowledge, skill, and judgment as a regulated health professional, as an audiologist. So this is not delegating a controlled act. CastlePro has a position statement on this. CastlePro's current position is that the controlled act of prescribing hearing aids cannot be delegated. And there is also a paragraph in the amended professional misconduct regulation, paragraph 4.3, which talks about permitting, counseling, or assisting a person who is not a member to perform a controlled act if the person is not authorized to perform the controlled act. And that would be professional misconduct. So this is, again, making the point that controlled acts must be performed by regulated professionals. This is grounded in the legislation. But Dara has not delegated that to Cami in this scenario. He has done that himself. So you might be asking, what does it mean then to assist a person to perform a controlled act? This would be if an audiologist either said to a hearing instrument practitioner or somebody, another team member, or behaved in a way where they allowed another professional who doesn't have authority to perform the controlled act to do everything themselves. So if Dara was to say, just go ahead and do all the steps, I don't need to be involved, that would perhaps be seen as permitting counseling or assisting someone to perform a controlled act. But in this scenario, that's not what has occurred. So we have another polling question to ask you about this same scenario. Could Dara, the audiologist, complete the prescription process for Sam using a virtual appointment? So we'll launch that poll and give you some time to respond. Okay, thank you very much for your participation. So you can see that 66% have said yes and 30% have said it depends. So let's have a look at our answer. And we are also saying possibly it depends. As audiologists, we are required to follow the standards for virtual care. And these standards outline some high-level principles, which are that we must consider if it's an appropriate service model to provide a virtual appointment. What are the risk factors for the patient of a virtual appointment? And is the patient going to be able to participate in virtual care? Is additional patient assessment needed? So depending on the patient situation, is more information needed about the case history, the needs and goals of the patient, their motivations, their financial considerations? What type of assessment do you need to do? And is the most effective way to conduct that assessment to do this virtually, or would it be better in person? So this is a professional judgment call, remembering that this is not a cursory review, right? This is an important clinical step and it's a healthcare service. So we need to ensure the patient's best interest, and this is where your professional judgment as an audiologist comes in, because you are performing the controlled act. So you have to decide if virtual appointments are going to be the best way for you to gather the information that you need to appropriately prescribe. So we have a last question on this scenario. It's not a polling question, but the question is, what are Dara's responsibilities in terms of the remainder of hearing aid services? So he has done the controlled act, he's done the prescription, but what about for dispensing, fitting, verification, validation, education, and counseling? And the answer is that Dara's prescription, as we've talked about, will inform the next steps. However, an audiologist can only be expected to meet standards for the aspects of service that they provide. So whatever Dara is going to do as an audiologist with the patient, he must meet standards for all of the aspects of service that he will provide. If he can't or won't carry out the next steps himself, the minimum expectation would be that he will ensure that he can be available to help or assist if there are questions arising from his prescription. So this means that he must collaborate effectively with the patient, with the hearing instrument practitioner, and make reasonable attempts to ensure that the dispensing, fitting, verification, validation will be as beneficial as possible for Sam. It also depends on the structure and organization of a workplace. CASLPO cannot regulate workplaces. CASLPO can only regulate us as audiologists, as the practicing healthcare professionals. And CASLPO can only uphold expectations for audiologists, not for other professionals. So if, for example, the structure of a workplace was that there was going to be a supervisory relationship between an audiologist and a hearing instrument practitioner, then CASLPO standards would apply for supervising another person who is helping with providing important patient care. And CASLPO has a position statement on this. However, we realize that this isn't always the arrangement. There isn't always a supervisory relationship. So it also depends on how the services are being provided in the particular workplace. Okay, so we're going to move now to another new scenario. Let's have a look at scenario 2.
And in this second scenario, the audiologist and HIP work separately. Marie is the patient. She's 58 years old, and she sees Carl the HIP at a clinic that Carl operates independently. This is Marie's first hearing assessment. She tells Carl that she has recently been experiencing sudden episodes of tinnitus and dizziness. She's also experiencing one now, which is why she's come in to see him. During these episodes, her hearing worsens and her ears feel plugged. These episodes last from a few hours to a whole day. Carl conducts the hearing assessment and finds these results. The audiogram with asymmetrical, low-frequency sensorineural hearing loss in her right ear, normal tympanograms, and Carl does not include acoustic reflex thresholds or speech audiometry results. Carl also finds that Marie has not seen a medical doctor about her symptoms, even though because they're recent but they have been worsening. She cannot hear well when she's experiencing an episode, which prompted her to have her hearing tested. She has a history of high blood pressure and takes medication, and she doesn't know about any family history of hearing loss. Carl advises Marie that she can consider trying a hearing aid for her right ear. He explains that a prescription for the hearing aid is required and asks for Marie's consent to send test results and other information to Kieran, an audiologist who has her own practice in the same community. Marie consents, and Carl sends the information in a secure and confidential manner electronically to Kieran. So let's launch the next poll. So please let us know, do you think that Kieran, the audiologist, can determine a hearing aid prescription for Marie based on the case history, audiometric data, and other information about Marie that was provided by the HIP? We're getting lots of votes in for this one. All right, close the poll.
Okay, and as you can see, the vast majority are saying no. This would not be a circumstance where Kieran would move to performing the Controlled Act and prescribing. So let's have a look at the answer. I think that most audiologists watching feel that this is perhaps kind of pretty clear. Our answer is also no. In this case, the practice standards would require that Kieran, as an audiologist, recommend involvement of appropriate professionals. So thinking about what we know about Marie, this is the first time that Marie is ever having her hearing tested or assessed. There are details about Marie suggesting underlying medical concerns that require a physician's involvement. And so in this case, the practice standards would require that we must recommend, refer, or advocate for a referral. So part of our competency is to recognize when a patient's presenting concerns are outside the scope of audiology practice. Looking at this case, this could possibly be something like Meniere's disease. However, this condition needs to be diagnosed by a physician. It is out of the scope of practice for an audiologist to make that diagnosis. So this same thing would happen even if it was an audiologist and hearing instrument practitioner working in the same setting, or an audiologist practicing on their own, because it's the medical concerns and the case history and symptoms of the patient that are the risk factors here. So more reasons why hearing aid prescription is not the next step at this stage. If the underlying cause of Marie's symptoms is in fact Meniere's disease, she will need more counseling on potentially the fluctuating nature of her hearing loss and the long-term prognosis. We need more information about Marie's symptoms and experiences of communication difficulty. We would need to talk to her about the barriers for successful outcomes. If her hearing loss will be fluctuating, the hearing aids may need to be adjusted quite frequently. So we need to consider this in terms of her potential for obtaining benefit. We also learned in this case that the hearing instrument practitioner did not include speech audiometry results. So we don't know much or enough about the severity of Marie's hearing loss and how that might impact her potential for obtaining benefit. We also don't have information about whether economic and financial considerations have been discussed with her, given her particular situation. So we need to counsel Marie to make an informed decision. So this is, again, highlighting for us the fact that prescription of hearing aids is not just case history and assessment data or a cursory review. All of this information needs to be carefully analyzed to determine Marie's candidacy. And in this case, compared to the first scenario, this is a different process for prescribing. So what does Kieran do? Kieran contacts and speaks to Marie, the patient, and explains her professional role as an audiologist in this process. She advises Marie that before a hearing aid prescription can be considered, she should have a medical evaluation. And Kieran confirms Marie's consent to share findings with Marie's physician and to advocate for a referral.
So let's fast forward into the future. And Kieran now knows that Marie has a confirmed diagnosis of Meniere's from an ENT physician. Marie is feeling better currently and would like to discuss trying a hearing aid for her right ear. Carl's clinic, the HIP, is closer to where Marie lives, so she goes to see Carl. The HIP contacts Kieran, the audiologist, again about the prescription. So what does Kieran need to do now? Standards require Kieran to use her professional judgment. And really, this is where it applies. She needs to address patient risk of harm and take the steps that are necessary in order for her to confidently prescribe a hearing aid for Marie. Kieran will need to decide if she needs to see Marie for an evaluation of her candidacy in person, conduct additional assessments, speak to the HIP about the next steps, request that the HIP conduct additional testing and share the results for Kieran's analysis, or conduct a virtual appointment with Marie. Will that be effective for Marie's needs?
So thinking about what could happen next, it could be that Kieran will determine after working with Marie that prescribing a hearing aid is perhaps not the best course of action. It really depends. This will be up to Kieran's knowledge, skill, and judgment. But let's imagine if Kieran does decide that it is appropriate to proceed with prescribing a hearing aid, and if the dispensing and fitting will happen with Carl, because we learned earlier in this scenario that Marie lives very close to where Carl is, so Marie might return to Carl for the next steps, then what are Kieran's responsibilities? According to the standards, in that case, if Kieran will proceed with prescribing, but the fitting and the dispensing will happen with Carl, the standards at minimum require Kieran to inform Marie of the importance of verification and validation of the hearing aid fitting, and to make reasonable attempts to provide this follow-up to make sure that Marie does receive those services. At the end, ideally, Kieran, as an audiologist, will continue to be available and involved in Marie's hearing health care. Kieran, as a regulated professional, is expected to be available for collaboration and consultation. So those are our two case studies where we've put into practice the Controlled Act and the standards. So we're going to move now to the last section of the webinar, where we will touch on record keeping and payment for prescription services.
So one of the questions that we received is, do audiologists need to maintain a patient record when they provide hearing aid prescriptions, but may not be involved in the next steps in hearing aid services? The answer is yes. Involvement with the patient, whether direct or indirect, is a healthcare intervention. A record is therefore needed. You need to keep a patient record for any clinical act, including hearing aid prescriptions. The records regulation, documentation standards, and standards for the provision of hearing aid services by audiologists all require hearing aid prescriptions to be documented in the patient record.
Okay, and now let's talk about payment for prescription services and some of the considerations here. So we'll begin with a quote from the CastlePo FAQs that were published earlier this year. and that is that audiologists are providing hearing aid prescriptions as a hearing healthcare service for the benefit of patients. The patient's best interest must be placed first and foremost before any professional interest. And the reason we're saying this is because audiologists can charge fees for their services. So if you are going to be performing the controlled act of prescribing, working with hearing instrument practitioners, and you're going to be spending time on this activity, because as we've covered, it's a controlled act and it's an involved clinical activity that where knowledge, skill, and judgment needs to be applied, then you can charge for this service. Audiologist services are not expected to be free. But the point we're trying to make here is that it's very important that we keep at the front of our minds that we are performing this controlled act because it's important for our patients, and they're relying on us as the regulated professionals with this competency. And that should be the most important thing. So some further considerations when it comes to payment. It's the consideration of time. So time is required to determine a patient's hearing aid prescription. This is a controlled act, and the time required will vary depending on the patient, factors, and circumstances. Recall the two scenarios we've covered today for Sam and Marie. So it's going to take a different amount of time because each of their hearing aid prescriptions involves different considerations. Again, this is highlighting for us that prescription of hearing aids is not a pro forma or strictly administrative task. There is comprehensive evaluation of patient information that needs to take place. We have to take steps to fill in gaps in that information and address risk of harm. We have to do a thorough clinical analysis, and we have to determine and document the prescription. This will take time, and it also could require collaboration and consultation, which will also take time. Thinking again about the different situations where this could be happening, again with the audiologist and HIP working in the same clinic, we would imagine that in those cases the patient is receiving one set of invoices. The professionals involved and their roles should be clear, and the payments are happening in one location. For an audiologist working with an independent hearing instrument practitioner, we would imagine that the patient is paying the hearing instrument practitioner for their services. But then what needs to be considered, or the question that we have heard, is how would payment be arranged for the audiologist's time spent on this clinical activity of prescription? So it is not Castle Poe's role to decide arrangements for payment or to decide payment amounts. Recall that the college also does not regulate workplaces or their processes, and regulatory colleges are not involved in this, involved in determining payment arrangements or fees. Castle Poe's role is to regulate our profession to protect the public. And so payment arrangements must conform to Castle Poe's regulatory requirements of us as audiologists when it comes to fees and billing practices. So if you are working with a hearing instrument practitioner and performing this controlled act, because we are regulated health professionals and held to a higher standard, we will be required to inform possibly the hearing instrument practitioner of the standards that we are required to meet. So what standards am I talking about? Well, these standards and principles and requirements are coming from the Code of Ethics. So what we have listed here are the principles from the Code of Ethics that would apply to charging a fee. And if we look at what these principles are that we must follow, patients have the right to collaborate in all clinical decisions and be informed of risks, benefits, and alternatives. So the right of the patient to collaborate for the prescription of hearing aids, that patients must be informed of fees for services and products. The explanation of fees must be clear, accurate, and discussed prior to the initiation of the service. The fee structure must be reasonable and based on fair values. We must not let personal or financial factors create a conflict of interest, and we must not engage in unethical business practices. These are ideas included in the principles of patient autonomy, patient benefit, accountability, and do no harm in the Code of Ethics. And so thinking about this, if we are going to perform the controlled act working with another professional, and these are the requirements that we must meet, this is going to influence how we set up a payment arrangement. How are we going to make sure that the patient is receiving the information they need? How are we going to make sure it's clear and accurate? We need to be thinking about this. Similarly, if we look at what is in the professional misconduct regulation, So this is a text-heavy slide. These are direct statements from the professional misconduct regulation paragraphs that explain what is professional misconduct. So prescribing, dispensing for an improper purpose, breaching an agreement relating to professional services or relating to fees, submitting or permitting the submission of an account or charge for services that the member knows is false or misleading, charging a fee that is excessive in relation to the services charged for, and failing to itemize an account for professional services if requested to do so by the patient. So again, thinking about what requirements we have to meet, what is defined as professional misconduct, how do we need to set up payment arrangements so that we can meet these requirements? So the takeaways are you need to be clear on the fees, they need to be reasonable, they need to be well explained. The patient should not be surprised. They need to understand what is happening in terms of their services and what the fees are and why they're paying those fees. So keeping in mind these expectations must be met, audiologists will need to consider what the best arrangements are for payment. So just some final considerations when it comes to payment. For audiologists and hearing instrument practitioners working independently, we need to ensure that the patient has access to the prescription. We need to ensure that we maintain confidentiality of patient personal health information and ensure appropriate consent for any intervention or for the sharing of personal health information of patients. And we need to be involved in effective collaboration and communication.
So we can review some of the things that we've talked about today. We started off by talking about the Assistive Devices Program and the recent changes. We talked about the Controlled Act and what it means to prescribe. We talked about making a prescription, relying on someone else's information. We looked at scenarios, putting these into place. And just now we covered record keeping and payment for prescription services. And that takes us to some time that we have now for questions. So actually, Samit, I'll give you a chance to read through the questions, and I'll start with one that we received beforehand. The question was, how will CASLPO deal with complaints against audiologists who decline to act as a prescriber for an ADP application? So we wanted to start off by saying that CASLPO is required by law to review and investigate all complaints, with the exception of frivolous and vexatious complaints, which follows its own process. If you decline to be the prescriber, it is essential that you document your rationale for why you decline. The FAQs in April discussed that if you feel you do not have all of the information that you need to prescribe and you're unable to obtain that information in the way you need to meet standards, you may decline the prescription. Audiologists need to remember that prescribing is a controlled act and you're required to meet standards. Each situation is individual and will depend on the circumstances.
Thanks, Dana. I'm just looking through the questions.
For sure, and I feel like I say this at any e-forum, but document, document, document.
Yeah, I was just going to add that this is why documentation is so important, because your documentation of what you do and your clinical rationale is your evidence of what has occurred. And that's extremely important in terms of being able to look back and see what steps you took and the reasons why. So there's one question here. It's an earlier question. Do audiologists have to be present during discussion of amplification options at all times with the patient? So again, I think it depends on the working relationship that you have with the individuals you're working with and your knowledge of their competency and how much information you receive and whether you feel that information is sufficient for you to be able to prescribe. So if somebody else has had the discussion and you get that information and you think there's still gaps, then you would be required to take steps to fill in those gaps.
Actually, a similar question that we just received. So I'm going to look off to the side to read it. If we keep electronic records, we still need to obtain consent from the patient to keep their personal information electronically. I think that's the first question. Yes, consent is of course needed. Can the HIP get that consent on our behalf? And the reason I wanted to put this question in now is I think that it goes along with what Samita was saying, that you need to be aware of the competence of the HIP. As a speech pathologist working with CDAs, for example, we'll make sure that they have a scripter or the admin staff that are at the front desk, so that when they're getting consent, we know what's being said. So if, as the audiologist, if you're someone that works with the hip and you know what it is that they say to get consent, then I think that's something that you can feel comfortable with. If it's something that you feel you need to talk to the patient for, that's fine too. It's again using your knowledge, skill, and judgment as an audiologist.
Okay, we have another question here. Can you define the word dispensed? Our office sends people out on trial prior to office dispensing. So dispensing, there's the definition of dispensing in the standard, which is the act of issuing the hearing aid to the patient based on the prescription. But trial periods, I think, are important, obviously, for patients so that they can see how much benefit that they are actually receiving from the device. So I think trial periods are very useful for patients. I wouldn't say that you've dispensed if you've offered the hearing aid as a trial. I mean, you've done a lot of the activities that are involved in dispensing, because I would think you'd set up the hearing aid for the patient according to their needs. But I would say that the dispensing has actually happened when the patient has proceeded with deciding that they would like to purchase the hearing aids, and then now the hearing aid is going to be dispensed for them to wear on a longer term basis based on the prescription. Also about dispensing, there's a comment here. It's surprising that dispensing is not also controlled because there's risk of harm involved with dispensing. And yes, that is true. The dispensing is controlled to the extent that it is dependent on the prescription, right? So the law in Ontario, as we've covered, is that a hearing aid cannot be dispensed unless a valid prescription by an authorized health professional has been provided. So in that way, there is a little bit of oversight on dispensing, but not as directly as the prescription. The patient can go to wherever they would like to have the hearing aid dispensed. So this is one thing, which is when you see a regulated professional, then there is confidence that for all steps of the process, that professional is being held responsible to meet standards.
I'll jump in with another one. One of the questions is, if the audiologist and hip are in the same clinic and give one invoice, do both clinician names need to be on that one invoice? So that's something we have there's lots of information in the records regulation, for instance, on financial records, but we also have a Did You Know that came out in the last couple of years for what needs to be on invoices. So the audiologist's name needs to be on the invoice. And then whoever provided the intervention, whether it was, I mean, in this case, because of the prescription, it would be the audiologist, but the HIP's name should be on there as well. And if you work in, say, a larger practice and you're not the one that's responsible for creating the invoices, then just a reminder that you, as the regulated health professional, the invoices do reflect you. So that is something that you should be aware of to see what is on invoices and if any information is missing.
Thanks, Dana. I see another question here. For clarity, is it required for the audiologist to meet in person or virtually, if appropriate, with each patient for which they are the prescriber? So it's difficult for me to imagine a situation where some interaction with the patient would not be needed. I think that this is a professional judgment call, but as an audiologist, I think that some interaction with the patient is necessary when you're going to be prescribing, but it's a professional judgment decision or an application of professional judgment to decide how that interaction needs to take place. So like we talked about when we were talking about the different scenarios we covered, in some cases, a phone call might be okay to touch base with the patient. Maybe they are experienced, they're hearing with using hearing aids, their hearing loss is not as complex. For other patients like Marie, who had a diagnosed Meniere's disease, that's not the same, right? You may need to see Marie in person. So what CastlePo is saying is, this is a professional judgment call. We are we are, as audiologists, needing to decide what type of interaction do we need to have with the patient to be able to appropriately prescribe.
I think you're going to hear some of the same phrases come out of our mouths a few times. There's another question here. At the beginning of the presentation, the Regulated Health Professions Act, Controlled Act wording indicated that the assessment must be performed by the prescriber. However, in the scenarios, the audiologist is not actually completing the assessment, but assessing the assessment. And that's true. But again, this is where knowledge, skill, and judgment comes in. And it's about the analysis, that you're taking this information potentially from a HIP or someone else, and you're incorporating it to look at the overall assessment, the overall analysis to see, is this something you're comfortable with? Are there any gaps that need to be filled in? Is there any more testing that needs to take place? It really can depend, it absolutely would depend on each patient and on each scenario, each specific situation and the individual patient to see, yep, I'm comfortable with the information here and this is what I think is best, or nope, we need to take some more steps to fill in gaps. Samita, I don't know if you have anything to add to that answer.
No, I don't. Okay, I see another question here. If we keep electronic records, we still need to obtain consent from the patient to keep their personal information.
Sorry, I think I did that one. I did that one already.
Oh, did you do that one? I'm sorry. Okay. The next question, how do audiologists determine if the hearing instrument practitioner is competent enough to provide assessment information, such as an accurate hearing test? Okay, so I think that would depend on the relationship that you have with that hearing instrument practitioner. So there is going to be a need to develop some type of professional relationship. I think this is an important question because you are relying on and collaborating with that other professional, and so you do need to know each other to some extent. If you do not feel that the assessment has been completed in a way that makes you feel confident with proceeding with prescribing, then you can be open about that. I mean, you can say, I need more information, or I'm going to need to assess this patient myself. But yeah, how do you know? It would be because you establish a relationship. There's another question asking, ODS have to keep patient records for prescriptions. What exactly needs to be kept in the patient record? If you look in the practice standards for the provision of hearing aid services, you'll see that there is a whole section that outlines exactly what needs to be kept in a hearing aid prescription by an audiologist. So I would recommend you have a look at that practice standard under intervention and the part about prescription, and you will see that it is laid out there. Okay. There's a question on who is enforcing that a prescription be present. As we've covered in the webinar, this is, the law. CASLPO is attempting to enforce this through providing this information. I think it's important that people know what the law is. And so it does, also fall on us as a profession to inform other people of what these requirements are. So in our workplaces, if we are working with people who are not regulated health professionals, they might not have as much knowledge about regulation and what the standards and what the legislation are. So in that case, it does fall on us to share this information.
We have a few questions asking if the audiologist can charge the HIP for the prescription instead of the patient. And this actually has come up a few times and it's come up slightly differently worded. So if I'm not asking it the right way, I apologize. So as Samita said, the way that the billing works and who is charged, that's not something that the college would be involved in. That's not our role. But you can definitely charge the HIP. It doesn't have to be direct to the patient. It might be easier if you charge the HIP instead. But again, consider the code of ethics, consider misconduct regulation, consider all of those things to make sure that you're doing everything appropriately, I guess. All right.
We have one last question about letters sent out offering prescription services to many clinics. So I think it's important to address this. So we've covered today what the important activities are in prescribing. And so this is really important, right? If these types of letters are going out, again, it falls on our profession to share with others the importance of the Controlled Act, the importance of what we do when we prescribe. And we talked about time. You know, it's going to take time, application of your professional judgment. This may not be something that people realize, and they won't realize if we don't talk about it. So it's important to share that with these types of situations. If you are being asked to do hearing aid prescriptions in situations where you feel you can't meet the standards, then our advice to you would be please speak to your employer. Use the CASLPO documents and standards as resources. These are documents that are always available on the website. You can direct your employer to them. You can also call practice advice. Dana and I are both, in addition to our roles in quality assurance, we're also with practice advice. And we are happy to speak to you if you have questions, and also with employers if they have questions. Okay, so it is 1:15. We have reached the end of our time today for the session. I would just like to again thank all of you for taking the time to join for this important topic. Please do connect with us. We did not get to all of the questions, but we will plan to respond individually for the questions that we did not get to. Thank you very much and enjoy the rest of your day.
Thanks. Bye-bye.